Rogers TV, Midland.
Opioid Crisis Pandemic 2. We're very pleased that you are joining us either on Rogers TV, which is being aired throughout Simcoe County this evening, or accessing us on your electronic device by streaming from either Rogers TV or from the Facebook Live feed. My name is Keith Rose, and I'm your moderator for this evening. Tonight, we have an opportunity to discuss with our experts opioids, more commonly referred to as powerful pain relievers, and the deaths due to opioid poisonings. This is a big problem, and unfortunately, it's getting bigger. It's growing. Last year, there were over 2,000 deaths in the province of Ontario, but in the last 6 months, there's been a very significant increase in the number of people who've died from opioid poisoning. The problem is complex and multi-layered, and therefore requires multiple strategies implemented by many organizations. Tonight, we will hear about the challenges and solutions to save lives. But before I introduce our 4 experts on the panel, I have a little homework to do. First of all, some comment about the Midland Cultural Center. It's closed right now, but we look forward to being back with live audiences sometime soon. Some collective thank yous to the Our Health Advisory Group, and specifically Larry Arnold and Holly Archer for putting this program together. To our 7 local sponsors, who I'll spend some time with partway through the program, telling you who they are and what they do. A big thank you to Phil DeBruyne, our local expert and advocate for police services, who has helped plan this program and enlist several organizations within the OPP to provide additional funding for this extra program. Also, many thanks to these OPP organizations for their support, a very tangible indication for their commitment to solving this problem. I'd also be remiss if I didn't thank the extraordinary staff at the Midland Cultural Center and here at Rogers TV. Thank you. Thanks, everyone. I normally do a big round of applause, but it's kind of hollow if I do it by myself. So you understand how I feel about your support. Our format includes a discussion with each of the speakers, followed by a question and answer session, probably about an hour through. It's not too late to send us your questions. On the bottom of your screen is Jared's email. Just send us questions. He'll pick them up and he'll pass them over to me. Join us for our next program. It's again live and online. It's titled Resilience, a Key to Happiness. That program will run 5 weeks from tonight. That's February the 25th, again at 7:30 p.m. Resilience is what keeps us going through challenges and diversity, times like right now. I want to learn more about it, and I hope our audience appreciates the panel that we put together to talk about it. So 5 weeks tonight. Now let me introduce our 4 speakers. Chris Martin. Chris, put up your hand. Chris is an ER and ICU doctor at Royal Victoria Regional Health Center. And I'd be remiss if I didn't say that Chris actually runs the community educational series out of RVH, which is very similar to the Our Health series. And we have talked several times before about how programs run, and they are quite different, but our content is actually fairly similar, but how they run it is different. Mia Brown. Mia, raise your hand. Hi. Mia is a public health nurse with the SIMCOE Muskoka District Health Unit. Jim Walker. Jim? Jim is a deputy director with the Ontario Provincial Police Services. And Melissa HURST. Melissa? Melissa is a mom who lost her son to an opioid overdose several years ago. 2017. Is that right, Melissa?
Yeah.
And has established a group called SIMCOE Moms for Overdose Awareness. So thanks to all of you for coming. More detailed biographies of each of our speakers are in your program. They're on the second page where we've put some information behind it. So either after the show or whenever you want, you can take a closer look at those things that came through the email on the promotional material. Okay, at this point, I'd like to ask an opening question of each of our panel. How did each one of you become aware of and interested in opioids? Chris, do you want to start?
Thanks, Keith. In my practice in emergency and critical care medicine, it's become increasingly obvious that the number of young people who've come in with severe overdoses and who have either died from these overdoses, had severe brain injuries, is increasing. And I see these as preventable deaths. This is, obviously a huge public health issue, a huge medical issue. And I'm very passionate about doing whatever I can to, help this issue.
Okay. Mia?
As a public health nurse and working in the substance use and injury prevention program, I am passionate about, population health and addressing the vulnerable populations within our region through the collaborative approaches that we take with our community stakeholders, the public health education that we provide, and the advocacy that we do at the various government levels.
Okay, thank you. But how did you get into it in the first place, Mia? How long have you been interested?
I've always been interested in public health.
Okay.
And then the, certainly working in the substance use and injury prevention program, when we started to see an increase in about 2016, 2017 in opioid emergency department visits and overdose deaths, our program really started to look at ways that we can work to address our local needs.
Okay, thanks, Mia. Jim.
Keith, thanks. Actually, before I was a police officer, I was a paramedic for the better part of 7 years. And in those 7 years, I could count the amount of overdoses I ever attended, probably on one hand. Shortly after my transition to the Ontario Provincial Police, and I started my career in drug enforcement in the early 2000s. And I watched the introduction of OxyContin and watched the metamorphosis of the opiate problem, right from heroin, oxycodone to the fentanyl patches, and now the fentanyls and the derivatives we're seeing now, and obviously the huge impact it's having, and we're seeing it obviously at frontline with policing. So, okay. So your whole career's been tempered by the opioid crisis and overdoses, okay, and the increase, like everybody else is saying. Melissa, I'm going to give Melissa a little more time here because she's actually going to recount the story of the death of her son. So, Melissa.
Good evening. I'd like to take a moment to thank Larry Arnold and Keith Rose for inviting me to share our son's story and to speak on behalf of SIMCOE Moms for Overdose Awareness. My son, Luke Kitson, passed away in the early morning hours on Mother's Day, May 14th, 2017. On the eve of Mother's Day, my husband picked Luke up from work. It was unusual for him to be home on a Saturday evening. We talked all night and laughed. And at one point he said he really could hardly wait to be a dad one day. He just said, "I'm not ready anytime soon," which we were thankful for. Bedtime came, we hugged. Our last words were, "I love you." I went to wake him at 7:42 a.m. to find that he'd passed away. His cause of death was an opioid overdose. He was just 19 years young. Luke was a caring, loving, loyal, and very funny young man. He loved deeply, was always up for an adventure, and always fought for the underdog. He was so emotionally connected with others that he often felt their pain as though it was like his. His life mattered. Our lives have never been the same. I miss him every waking moment. I wake up with pain and brokenness. A part of me died along with Luke that morning. I've come to realize that the pain will never go away, and I'm learning to find joy through the pain. Luke didn't plan to die. He was not an addict. His death was caused by an accidental overdose with a recreational drug that was laced with fentanyl. He was planning his future as this happened. His death has impacted so many people. The ripple effect is just staggering. And those who knew him, including his brother, will never be the same.
Thanks, Melissa. Tough story to tell. You've told it many times. Does it get any easier by telling it?
No.
No.
I relive it every day.
Okay. At this point, I'm going to turn our time over to each of the individual speakers, and they're going to talk about how they approach in their own individual lives, because they're all from very different backgrounds, how they approach the opioid crisis and what they're doing to solve this. And it will take several different forms depending on the speaker and their walk in life. So let's open it up with Chris. Do you want to start, Chris?
Thanks, Keith. And unfortunately, Luke's story is tragic, and it's unfortunately not uncommon. And you know, the sad part is it's continuing on, and we see it in the emergency department. So what I would like to do is like to walk through kind of how an opioid overdose can move through the medical system and what we're trying to do to kind of help that. If someone, as in Luke's case, and gets a recreational drug which is laced with fentanyl, or is using fentanyl intentionally, it's got such a narrow margin of error, and the drug concentrations are not known. So these overdoses are happening more frequently. The individual may be found by a friend, passerby, family with slow breathing, decreased level of consciousness, or non-responsiveness. And the first thing if paramedics are called, they'll administer Narcan. And Narcan is also called naloxone. It's the reversal agent for narcotics. And you can administer it either by intramuscular injection or with a nasal spray, similar to a decongestant. And this is available now freely at any pharmacy with a health card. And that's one of the strategies as a mitigation strategy for these overdoses. Family or friends, paramedics, police, fire, whoever administers the drug, naloxone, then call 911. The patient makes their way into the hospital if they're able to be revived. Once in hospital, we can put them on an infusion of this reversal agent and hope that during that time, they were breathing enough to not cause any brain damage. If they are able to be revived, we wait till the effects of the drug wear off, which can be considerably long depending on which opioid was involved. And then after a period of safe observation, they are then discharged home. And the hope is when they're discharged home with a plan, which is I'll get into after, of kind of how the medical community can potentially improve on our management and how we can help this opioid epidemic. Let's take an alternative solution or situation where, unfortunately, the patient, the individual, has been not been breathing effectively for a long time, and unfortunately now has had some damage to the brain from lack of oxygen. And this is the common method, unfortunately, of brain damage or death of someone who's overdosed on an opiate. Opiates cause suppression or decreased breathing in an individual. It's caused the breathing to slow, to become shallow, and eventually your oxygen levels fall. That person comes into the emerge and they don't wake up. Then they come to me in the intensive care unit. And there we play a little bit of waiting game down to try to protect their brain. And we hope that the brain damage isn't severe. Too many times the damage is severe. And at that point, you're looking at either catastrophic brain injury or a situation where there's significant injury and a long rehab, essentially like a bad hand injury from trauma. The scary part is that when we see these patients come in back in the day, and I would say even 5-10 years ago, it was mostly heroin, and we always used to send off toxicology screens to see what was in the drugs. And no matter what they overdose. Now fentanyl is so prominent. We don't even bother sending the tox screens anymore. We know it's in it. It always comes back positive for fentanyl. And with that trend in the positive fentanyl have come more and more people through the doors. And unfortunately aren't just waking up and emerge and going home. More of them either are making it into emerge because they've been declared dead on the scene, or they come in with brain injuries and end up with me in the intensive care unit. It's a very traumatic for the families, as you can see. It's life-altering for the individuals. Often patients who aren't hardcore drug users. They're using what they think is something else, ecstasy, cocaine, other recreational drugs that are just laced with fentanyl. And I'll let my colleagues in the panel speak to why that is. And these are just tragic. We always used to say, using recreational drugs is risky. It's never been more dangerous than it is today. Now, to the question of, okay, so what can we do about this? What can we, how can we change things? Definitely from the hospital's perspective, the one thing is that, some of these patients use repeatedly, and the risk for dying from overdose is a previous overdose. And I think that from a medical perspective, we have to do a better job of follow-up, of referring these individuals to treatment centers for addiction, and also using medical therapies to aid in their successful treatment. And I can get into later, Suboxone, methadone, that kind of treatment as well. And as well, making sure they have a supply of Narcan. Okay, there's no, as we'll probably find on this panel, there is no single solution to this problem. It is a multidisciplinary, multifaceted solution that needs to be addressed, and it's going to involve everybody from law enforcement, medical professionals, social services, health and addiction services, to remedy and even to make a dent in it, because it's unfortunately right now we're not winning this battle. We are losing it, and we need to make some significant changes to get back on track.
Chris, you and I talked before this event tonight, and one of the most distressing things you said to me is when you sign a patient out of the ICU, you've given them Narcan a couple of times, they wake up, they've had no brain injury, in medicine, a success, but you send them out the door knowing that they're going to come back again, that's the part that bothers you the most. So how do you maintain your enthusiasm for this with that discouraging kind of outlook as you discharge a patient that you have saved his life and made him better?
I think, yeah, Keith, it is a tough one, because I think that we try to do our best to offer treatment, and accessibility for addiction services is probably the biggest barrier. It's gotten better. We have the RAM clinics available. We have prescriptions, but it's so complex of addiction and why people continue to use. And that I think that you just hold on to the hope that you're going to get through to somebody, that they're going to follow through with their addiction counseling. You've given the best chance of success. And it's that hope. And there are success stories. There are definitely people that beat this and that go on to contribute to life, have families, be there for their loved ones. And I think like any other situation where you don't know what the outcome is, you have to hope that patient's the one.
So Melissa talked about her son who was using recreational drugs, which is one way these patients present, and then they get something that's laced with fentanyl. There is a group of patients out there that have been receiving opioids for chronic pain. Can you make some comments about how you talk to your colleagues about how they should or should not prescribe opioids for chronic pain patients? Because there's a huge variance here. Like, you got chronic pain patients writing very passionately, "Don't take my pills away." And yet you have other people that saying, if those darn doctors would stop writing the prescriptions, this would just go away. Talk to us about that, would you?
Yeah, it goes all the way back to some pharma companies knowing that OxyContin was addictive and still marketing it to physicians as this non-addictive pain medication. And that was, it's propagated from there. I think that there's always a challenge, but treating acute pain and then chronic pain is a specialty amongst itself, and we have some excellent chronic pain physicians in the area. And it's not just narcotics, it's non-narcotic alternatives, it's local anesthetics, it's blocks. And so, my message is, there's a time and a place for opioids, but it's very limited. Chronic pain is a complex thing that needs complex specialists with specific training to do it well, because it is life-altering for those patients who have chronic pain. And escalating opioids is not the solution, and it usually doesn't result in a good quality of life for the patient and potentially risk. Every addict or every person who I know who's been addicted to narcotics has a story. No one, I've talked to after they've woken up and I give them Narcan and I've said, how did you get into this? No one's like, well, I was successful, I had a great family. I just decided to get into fentanyl. It's usually they've had something traumatic, either an injury, surgery, life experience, something that's, that we could see is happening to any of us. And I think that if they get into that position, they need to be referred to a specialist in chronic pain or addictions, depending on why they're on the narcotics, who can deal with their issues in a multidisciplinary facet, because there's no special drug to get you off. It does take a village, so to speak.
Okay. Thanks, Chris. We'll come back with questions, I'm sure. Melissa, public health, the kingpin in a lot of the strategies and a lot of the leadership around the opioid crisis. Tell us what you're doing in public health and what your focus is on.
We know that the opioid crisis is not abated during the global pandemic. And so as a health unit, we continue to prioritize the work of the pandemic response in our region, but we also prioritize the opioid response through our substance use and injury prevention programming. And so based on the activities through the SIMCOE Muskoka opioid strategy, we are continuing to work with our community partners to address the needs of our communities through needle exchange program, through our naloxone distribution program, and through the continued work of the drug strategy, the regional drug strategy. So I'll give a little bit of a background on the SIMCOE Muskoka opioid strategy. It formed in May of 2017 under the leadership of our Associate Medical Officer of Health, Dr. Lisa Simon, and the North Simcoe Muskoka Lynn, Dr. Rebecca Van Ursel. A think tank occurred in May of 2017 with a number of community stakeholders across the region to address the issues we were starting to see with increased emergency department visits for opioid overdoses, and as well as the overdose deaths that we were starting to notice in our region. Based on that event, we formed pillars, which are typical of drug strategies across the province and nationally. So we formed a prevention pillar, a harm reduction pillar, an enforcement pillar, a treatment pillar, and an emergency management pillar, with underlying foundational pillars of data and evaluation and people with lived experience. And so an action plan was created, and it was a 3-year plan that started in 2017 and was to end in December of 2020. The reason why, so at this point, we are continuing to do the work. We recognize that even though the action plan that we created was to end in December, because of the pandemic, we as a collaborative have decided to continue the activities within that plan. And then when there's capacity by the partnerships, we will look at what the future of our drug strategy will be in 2021 and beyond. I don't have the time tonight to go into detail about all the work that's happened in that action plan for SMOS, for the SIMCOE Muskoka opioid strategy, but you can visit the county hosted website, and it's called preventod.ca. Our SMOS work plan, our updates, our dashboards, and all of our pillar information is all located on that website. As a health unit, we also participate in the prevention pillar work and the harm reduction pillar work of the SMOS strategy. And so as far as prevention work, we continue to promote addressing root causes through the Alberta Family Wellness Initiative, which really focuses on early childhood brain development and the impacts that adverse childhood events have on the brain in early years. And so we hosted a workshop 2 years ago that included a number of social and health and educational partners to really encourage the understanding of the impacts that the early years have on brain development, and if there and when there's risk factors that come from early adverse events for children, or they call them ACEs, it's adverse childhood events.
So Melissa, I'll just stop you there just for a second, because when you use the term root cause, I think all of us, our ears perked up and think, oh, if we could figure out the root cause, then we don't need naloxone anymore. We don't need emergency departments. We can get rid of it right at the root. And you mentioned early childhood development issues and trauma. Is that the only root cause, or are there other root causes, or are we not there yet? I'm just trying to where that fits in.
From the research, we know that certainly traumatic events and early childhood adverse events can pose as risk factors for addiction and adverse mental health outcomes. And so that's part of it. And certainly we'd already discussed the concerns with prescription opioids and the addiction that's come from the prescribing of opioids for pain management. Okay,
thank you. Thank you.
So yeah, there are a number of activities that we are doing from a prevention point of view. We also have a staff epidemiologist who monitors our weekly emergency department overdose visits, and we alert the emergency response pillar when we start to notice increases or clusters of incidents of overdoses in some of our communities or hospitals. We also provide harm reduction supports through the harm reduction pillar, and that includes our needle exchange program.
I was new to this until we did an addiction program on Our Health a couple of years ago, and actually didn't understand harm reduction. So maybe it would be helpful if you talked a little bit to our audience about what does harm reduction mean versus the classical abstinence. Just don't do drugs, just stop taking them. Harm reduction is something very different. Can you just explain that to them?
So harm reduction is it's a pragmatic approach to addressing the opioid crisis, in that we meet people where they're at with their drug use, recognizing that there are various degrees of people's interest in participating in treatment services. And so harm reduction really just works to reduce the harms while they continue to use the drugs that they are using.
Okay. So recognize that they're not going to stop. You just have to make them put them in a safe environment, essentially. Is that it? So tell us what are some of the things you're doing in the harm reduction strategy.
So part of the harm reduction work that we do is providing needle exchange program supplies through our community partnerships. There's a provincial program called the Ontario Harm Reduction Distribution Program. Our agency services our communities with supplies to provide new needles and smoking equipment for people that are using drugs. We also supply disposal units to those partners as well. So it's a prevention measure when we look at the rates of HIV and Hep B and C through shared needle use. And so it was initiated for that purpose, but certainly we recognize there are other benefits to providing new needles. It reduces risk of sepsis from injection or infections that can occur from sharing or using soiled needles. And so there is a lot of research that suggests that harm reduction does reduce harms and is it's very cost effective to the healthcare system as well.
Okay.
So through the needle exchange program, we do distribute to our community partners across the region. We also provide naloxone through the Ontario naloxone program. So as well as the the pharmacies in our community distributing naloxone, we as a health unit service our region by providing naloxone to our community partnerships so that they can train individuals in the community and the public on how to use naloxone. And then we also provide naloxone to our police and fire departments for emergency response purposes.
So I'm going to make an editorial comment here. I said we did an addiction program on Our Health 2 or 3 years ago. And at that point, everybody was talking about the wonderful effects of Narcan and having it available. But they were still arguing who gives it, the police, the pharmacists, the bystanders, the emergency docs. There wasn't a clear indication. And what kind of training did they have to give? And what kind of dose did they have to give? Rather than just give the drug, which tends to be the philosophy now. But you know what? That change has taken place in just a little over 2 years. So we get discouraged sometimes about how slow things move. That one, I would say, has been a very quick fix.
Absolutely. Yeah. And certainly anybody can administer naloxone. It doesn't require a medical directive for people that are administering in the community. So we do train family members and friends and people that use drugs on how to safely administer the naloxone, whether it's injectable or the nasal spray. And our community partners are all trained through the health unit on how to administer naloxone in the event of an overdose.
Good. Okay.
So one last piece of the work. Oh, sorry.
So sorry.
I should mention that we are. The one last piece that I would mention is that we are also a co-applicant on the supervised consumption site application for the city of Barrie. And so we, for the last 2 years, have been working with community partners. The Canadian Mental Health Association Simcoe County branch is the lead for this application in Barrie, and the health unit operates as the co-applicant. So we're right now in the
just
process.
a little bit describe what is a supervised consumption site, because they are unique, and our audience may not be aware of just how forward-thinking this part of the equation is.
So this again is a harm reduction strategy, and that you might hear supervised injection sites, supervised consumption sites, or consumption and treatment services. They all essentially mean the same thing. In the province, we call them consumption and treatment services through their application process, but most people know them as supervised consumption sites. And so what they are is they are a facility that operates under the care of healthcare staff, harm reduction workers and peers, to provide a safe, clean space for people to use their own drugs that they bring in under the care of the healthcare staff. They use their drugs. They have the supplies to use their drugs available to them and disposal available on site. They also have access to wraparound service information and support. So it's an opportunity to work with someone who is in the drug using population, who might benefit from accessing other health and social service and treatment services. And it's a way to start that conversation and make some improvements in their life, whether it's through helping them access social services or housing supports or treatment services in the community.
So for someone in Simcoe County, where is the closest safe consumption site?
Toronto would be the closest. We have a number of them operating in Toronto. We actually have 16 operating right now across the province under the provincial application process and funding. There's a couple of other sites that are operating outside of the provincial funding, but there are 16 right now that are provincially funded right now.
So recognizing we don't have it in our area, we don't have them in our area, are there things that people can do that in terms of when they take drugs that will replicate some of the things that a safe consumption site would do? So I'm getting at, not being alone when you're taking drugs, going back to Melissa's son's problem. If you're going to take drugs, take it with other people.
That's right.
Tell people what you're doing. Other things?
So we have, somebody would be using under the supervision of healthcare staff. We would have access to oxygen and naloxone on site. So, there aren't overdoses that occur on site that can't be responded to immediately, which would be the difference of someone using alone somewhere outdoors or alone in a home where there's nobody to respond in the event there's an overdose.
Okay, thank you. I'm sure we'll get back to some of the questions on this because it is a new concept and some people have trouble with it. I think those people that are in the field have recognized that this is maybe one of the best ways to prevent the opioid overdoses. So, Jim.
Thanks, Keith.
Jim, let's help us understand the role of police services. I think we've classically thought of you as the enforcers, get the bad guys out and prevent those guys from lacing the drugs with fentanyl, and that's your job. But I think it's far more than that. So tell us about what you do.
Yeah, Keith, our jobs evolved through this crisis. And so some of the key areas that we're working really towards is obviously the continued collaboration with our community partners. Mia mentioned locally, obviously the SIMCOE Muskoka opiate strategy. I lead the enforcement pillar there, but we have representatives from Barrie City Police, South Simcoe Police, RAMA, as well as members from the military police in Base Borden. But as this has evolved, obviously every community is unique. We have a bit of a different view being a provincial service. So seeing the number of communities we are responsible for, every community has different social services, health services available to them. So we're really cementing those relationships and working towards, alternative pathways for those people that have been identified at risk, before they overdose and getting them referred to the right services. When we started to see this crisis as the OPP, we were one of the first services to start issuing naloxone to our officers. And truth be known, that was a preventative measure because we were seeing so many unknown powders that were laced, we believe laced with fentanyl. It was an officer safety, but then it only made sense and especially in the remote communities where sometimes we're the first ones to respond. So we've been, since 2017, issuing or administering naloxone. But along with that comes, and Mia can attest to this with harm reduction, there's that balance of people being afraid to call 911 because they're afraid if the police come, they're going to get in trouble. So we have taken a lot of work ingraining the Good Samaritan Drug Overdose Act into our officers. And that's embedded in all of our opiate policy. And what that is obviously it gives a bit of protection to those individuals who call 911 for an overdose.
Does this mean that if I notice somebody overdosing, that I can just call the police and I don't have to be a witness, I don't have to be part of the conversation other than to help, and I don't have to appear in court to say this guy was using drugs he shouldn't have been using? Is that what the Good Samaritan Act does, Jim? Sort of.
It's more to protect you legally that if you're calling, you're not going to be charged with the simple possession of drugs or cannabis under the Cannabis Act. Or if you're breaching conditions of parole or a pretrial, you're not going to be responsible. What it doesn't protect you from, though, is drug trafficking. And so our job, obviously, is community safety, and we've taken the stance as an organization that we will respond to all overdoses. And our utmost priority is the administering of first aid, and if it's naloxone, then and then, identifying those people that are at acute risk and trying to get them referred to the appropriate community services. We also, if I think the doctor mentioned it, fentanyl's here, it's prevalent. If we go back a couple of years, we were seeing it laced. It's in everything now. What we do when we're seeing, or we want to be aware of what's the next substance. So we have ion scanners or presumptive testing devices that we can test all drugs or any of the substances we find. And the idea with that is that if there's something new or there's a really potent batch or something, then we can share that with Mia and her group to get that out to the people who use, so that they can be at least somewhat educated that there might be a new substance there. And again, that comes back to just a bit of a shift in making sure people know what they're taking. And then
So
it
Jim,
comes back.
you say that rather nonchalant, a bit of a shift. I think it's a huge shift for police services, primarily what we think of as enforcement versus somebody that really now is looking at the preventative side of the whole thing. So, and I think that your shift has occurred in what, over 2-3 years, something like that, or?
Yeah, like I said, and I said, and again, I go back to the doctor mentioned, we realize this is, there's not one pillar, there's not one branch that's going to solve this. And that's why we keep going back to the community partnerships. It's going to take an all hands approach to mitigate this. But then I do come back to our core function, and that is thorough investigation. So if there is a fatal overdose, then we will investigate it. And, that is to source that drug, source the traffickers, source that supply, and then ultimately hold those people accountable. Some of the successes is in the last 3 years since we've been administering naloxone, we've actually administered over 100 times across the province, equating to 100 lives saved. And so I say that because there was a stance of whether or not police should have naloxone or they should be attending that. But in some of the communities, we are the first ones to attend, and that is our focus now. So.
Okay. The other big change that you and I talked about was at one point when somebody died, there was a death and a police officer was in attendance. There had to be some fairly significant paperwork filled out, and not something that when they attended and the patient was already dead and there was nothing they could do, they particularly wanted to do, and therefore may not have been as engaged as they might have. And to get rid of that work, that extra work, which some saw as non-beneficial. How did you introduce that, and how did that happen so quickly?
Sorry, can you just rephrase that again? I'm not sure.
So I'm just talking about what used to be mandatory for an investigation. If an officer attended and a patient had died, there was a mandatory investigation, and now you've minimized the work involved in that for your officers so that they're more
I would say
willing.
I would say it's now more than ever. I think what you're referring to is the conversation we had about SIU notification.
Yes, it is. Yeah.
Two separate things. So I'll cover that off. Was obviously the special investigation units is the civilian oversight of police that is obviously enacted or notified when there's a death or an injury involving a police officer. So obviously when you're administering naloxone and unfortunately maybe not successful. So I can tell you the government was very quick to and SIU to as of 2018, it's no longer a mandatory notification. Back to the investigations. No, we are doing thorough investigations.
Okay.
What I want to be clear is when our officers attend, the initial response is that to administer first aid and help who's there. Then there is a thorough investigation done into trying to source the drugs and trying to see where they came from and ultimately hold that dealer, the supplier, responsible.
How difficult is that? Are these people totally underground, or is this into your total field, which is organized crime? Are these people easy to identify, or how do you go about it?
Without getting into total trade secrets, obviously, we look for the evidence and we'll follow the evidence. And that's ultimately, I think, the message I want to people to take away is we're not looking to arrest the people that are using. We're looking to arrest and bring those people to court that are, poisoning the communities in effort to make money at the end of the day, right?
Mm-hmm. 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 Okay. What's on the horizon, Jim?
Right now, obviously, the pandemic has obviously I don't want to say shifted the spotlight because it's actually probably increased the problem. But the thing we enjoy here in Simcoe County is we enjoy, the OPP enjoys a great relationship, I already said, with Barrie City Police, South Simcoe, Rama, and the MPs out at base board. And so we're always working together, looking at the future investigative enforcements. And then, you know, keeping our eye and ear to the ground on, you know, what's the next thing around the corner? Is there another substance that's coming in to take their place, right?
You briefly alluded to the COVID situation. What has that done to drug supply?
It's disrupted it, I can tell you that. Mia could probably speak more to it from a lived, lived experience input she's getting. But obviously, with the borders and the restricted travel, it has, it's disrupted the supply. And so what we see is, the dilution of, say, a fentanyl supply in a community like Orillia or some of these smaller communities, and then the introduction of a new supply that's much more potent. Historically, that's when we start to see the rash of overdoses.
Okay, thanks, Jim. We'll come back with questions, I'm sure. Melissa, do you want to carry on and tell us more about what you've done to heal yourself, what you've done with your work with Simcoe Mums for overdose awareness, and spend some time on that for us?
Sure. So as all of you will feel, those of us who've lost our children or loved ones, we miss them every single day, every minute and every second. And the grief and pain is there every single day. And the truth is, a piece of our hearts were ripped out the moment they passed away. We wish so much that we could have more time with them, but the reality is we don't, not in this life, and nothing we do will bring them back. So we were all left with a decision to make. We can let our grief and pain destroy us and our families, or we could use it in a positive way that would honor our loved ones and help others. We're all proud of our loved ones and the people that they were, and all of our children want us to continue to live our lives. The truth is, we'll never be the same. We'll never move on or get over it, but we can move forward, and we are moving forward. Simcoe Moms for Overdose Awareness was born as a result of many mothers coming together. And it's not just mothers, it's any family member, anyone who's lost a loved one is invited to be part. The biggest reason was we don't want anyone else to have to go through the pain and suffering that we've gone through. And there wasn't a lot of, we had professional help available and support. However, there was a lack of lived experience support and the freedom to want to talk about it, because unfortunately there still is a stigma attached to drug use, and it's something that we have to really work at to overcome. And one of the biggest things that we're doing now is we're advocating for those who are suffering with addictions, who have suffered in the past. And I think the most important thing is not to undermine the others, but we're advocating for those who don't even know yet that they or a loved one will be suffering in the future. And each and every person matters, and each and every life matters. We're losing valuable lives and individuals to the opioid crisis, and it's right here in our own backyard. Today, trying drugs for the first time can kill you. We need to stand as a community, love each other, and accept each other as we are, and where we're at in life, and where each individual is in his or her life. And I think this is really important that we grasp this as a community. It's recognizing that it's not up to us to judge or to make individuals be who we want them to be. And I think this is critical because we live in a throwaway society. And it's easier for us to wash our hands of problems and individuals who we feel are broken than it is to help them and want to show love and support to them. I really believe that somewhere along the way in all of this, our society has lost grace. We certainly want grace for ourselves when we need it, and yet we're not necessarily willing to give others grace. We have to come back to that. We have to let those who are suffering with addictions and mental health know that they matter and that we're here for them, not just in the moment, but we're here for them throughout their journey. And the issue is that the journey could be very, very long. It could be years, but they need to know that we will not give up. It does not matter how long the road is, that we are here. And the day that I don't stand up and believe this is really the day that I shouldn't be part of my community or any community. We have to work together. We're losing our loved ones at an alarming rate. And I think there's still a large majority of our community that doesn't even realize how severe it is. We need to hold all levels of government accountable to recognize and take action to help minimize the loss of lives. And we need to, as I said again, to stand together. SIMCOE Moms for Overdose Awareness, we had an online petition going that we will be sending to Prime Minister Trudeau for a call of action. We haven't sent it right now because of the COVID pandemic, and we're waiting for that to be controlled, better under control before we will send any of that off. And the biggest thing is we need to work alongside paramedics, police, fire, and our doctors and nurses who are on the front line dealing with this every single day. This is a team effort. And I encourage everyone who is listening to go home this evening and to decide what you can do to make a positive difference that will impact the lives of those here in Simcoe County and beyond who are struggling. And it's okay to not know what you're going to do right now, but it is not okay to do nothing.
Thanks, Melissa. It must be, well, we appreciate the strength you have in making this presentation, because you do have to live it every day. And as you advocate to put other things in place, it brings back the pain and the memories every single day. So, and nothing, as you say, will take that away. Melissa, Mia talked about the pillars and many people who are working on this. Is it easy to get your voice into the mix of the other very largely professional groups that are advocating for change and differences to happen? Because you always say when you get the frontline, very frontline people, which is the patient, in front of the committees, it's much more meaningful. So can you get in front of these committees? Can you give people like Mia your input?
Absolutely. Yeah, I'm part of actually different organizations that are here helping. And I can say every group and organization and professional organization is very open to lived experience and to hearing our I hate using the word criticisms, but things where we found roadblocks and difficulties, and things that have worked very well for us. And we're in collaboration with them. And I think that is key, that people also understand that it's not us and them, it is we, and we are all working together to make this a better community, and I'd like to see it to one day where we will have a handle on the opioid crisis.
How do you approach people that may have felt that the shaming approach is an effective one. You just tell these people they're bad people. How do you approach people that come with you and I mean, it must make you very angry, first of all, because you have your son and his memories, which wouldn't say, but how do you approach them? Because sometimes these have been fixed for generations or just the way they've grown up.
And I think that's a really important question. And the stigma is there, and I'd be lying to say that it isn't. It's not with everyone. I have experienced it. We have experienced it as a family. Not with those who truly love us. I don't hold judgment on them. I think a lot of it is education. The truth is, everybody is allowed to have their opinion on something. Mm-hmm. Whether I agree with that or not is irrelevant. It is, I think the key is education. And I think there is, until it really happens to you, you don't really understand. And that's not to slight others and those who are working together to, in this crisis. It's just, that is the reality. And we have to understand where others are coming from. Not that I agree with them, but I think until it really happens to you are affected by it, you don't truly grasp the situation.
Okay. Maybe now's the time to ask about decriminalization. There's been a lot of stuff in the literature on will it help if we take away the crime or the charges that have been laid for people who have been convicted of drug offenses? And I'm Jim, maybe you're going to have to help me on this, because I don't think it's necessarily the dealers you want to decriminalize, but what is it they want to decriminalize, and is that in your mind something that might work?
So there's a lot of talk about decriminalization, and I think it's important to your point to say it's not the dealers. Decriminalization would be removing the criminal penalties surrounding the simple possession. But I think it goes back and just to hammer away at and reiterate to Melissa's point is before that, I think from law enforcement, we are trying to do a better job, and like stigma keeps coming up, and really driving home the anti-stigma surrounding this, because what I don't think's been said here is that this affects all walks of life. There's not one single population that's immune to this. Melissa said you won't obviously know if it impacts you, but having seen it from a frontline enforcement to a position I'm in now, I've seen it impact people with professional careers that simply got an injury, prescription for chronic pain. They're all walks of life. So I think I just wanted to reiterate, like police now, we're just starting to roll out anti-stigma training to really start addressing that issue. To the point of decriminalization, again, it's looking at simply reducing or taking away the criminal sanctions around simple possession of some drugs, right? Mm-hmm.
Mm-hmm. And from a lived perspective, sorry to interrupt, I really am in favor of that. We are in favor of that. And instead of using, the money that was used to incarcerate users, to redirect that money to help in treatment.
Yeah. Okay. Thanks. We are at about the hour time of our event tonight, and I said I was going to take a break to thank our sponsors, so I'm going to do that now. TJ is going to put a slide of our sponsor logos up. So we do give a big thank you to our sponsors. They not only provide us with funding to maintain these programs, but also they provide all of us with the support and the promotion for each of our events. So thank you very much. We have 7 sponsors, as I said. We have 2 individual healthcare providers. They are Anita Federici and her Psychology and Emotional Regulation Center down on King Street in Midland. We have Audia Hearing Aid Center, and that's Andy Audia's work with hearing clinics across the SIMCOE and Muskoka region. We have 2 large healthcare organizations who are sponsoring us, Georgian Bay General, and as I look at the news for Georgian Bay General in the last month, wow, the highs and lows that organization's gone through, it's amazing what they have done to survive and come out successful. The Hillcrest Village Care Center, Walter and Jonathan Enns. I can't imagine what they go through every day trying to make the necessary changes and keep their patients safe. The activity and the work is unimaginable. I just can't figure it out. Anyway, they've chosen to sponsor us. We thank them very much. The Our Health series has 3 new sponsors this year, Lab X Media, Bob Cafto and Jamie Burns and their scientific group. We thank them. The Lipton Group, which is Lois Lipton and her group of real estate brokerages, investment and development companies, and Mink Insurance, who is now a part of McDougall Insurance family. So thank you to those 7 sponsors. This is my commercial break, but it's also a chance to say we really appreciate what you do and your support of this program in so many ways. Thank you. So we are going to turn to questions from the audience, but maybe I just open it up first so nobody's too shy. Do you have questions of each other? Okay, why don't I come back to that then? Okay, well, this was a surprise question. I didn't tell you about it in advance. So you can come back at it, and feel free to enter. If I ask one person the question and you have a comment, feel free to be part of it or ask other questions. So I'm just going to get my notes here. So I'm going to come to the questions that were sent in previously. How are other countries dealing with this? Why can't Canada figure out this importing stuff and get rid of it? So is this a Canadian? I know it's worse than Muskoka SIMCOE, but are other countries dealing with the same thing? Who wants to handle that? Jim, Chris?
I'll take a stab at it. So to answer your question, obviously SIMCOE is above the provincial norm that we've seen. One of the questions and one of the things I didn't touch on was the data. And, one of the questions we get is, why is it in SIMCOE? Why are we above? Well, we've really worked hard with the opiate strategy at kind of looking at all of our data from our different pillars. So from law enforcement, when we have interactions with people that use drugs and from non-fatal overdoses to, their admittance at the ER. And we do have a project right now going on with the opiate strategy that's enlisted the help of Stats Canada to take all those data sets and really look at, and it's all anonymized. There's nothing identifying except the age and sex and the demographic background and social economic, but looking at who this is impacting, the who behind it, so that when as a community, as a government, you're starting looking at, you have evidence-based decisions. When you start to talk why we do this like other countries, I'm not sure if the question is other countries and some of their solutions. We hear a lot of the Portugal model and things like that. But when you look at those models, all of them have invested heavily into treatment options. So I think, again, it's not a criticism. It's just that's where I think we have to have more resources. And I'm sure Mia could probably attest to it better than I. having treatment on demand. If one of my officers has an interaction with somebody and they say they want help, having the ability to get them the help that night, not in a couple of days.
I'm going to come back to you in just a minute, Mia, but Chris, your colleagues across the continent and US and even broader, what are they seeing?
So, I mean, this other countries, like the US is in no better shape than we are. And, maybe Jim can comment on this, but, our impression is that as the borders close and as you get more successful in shutting down the drug supply of drugs coming in, you're also shutting down like heroin and stuff, which is less lethal than the fentanyl, a lot of which is easier to get in because it's smaller, more concentrated, or it's produced within our borders. So controlling the border doesn't help you if you have people making it inside our own country. And I mean, across the board, this is getting bad. I mean, Vancouver's seeing their worst overdoses rates with the pandemic. The US is in trouble. As Jim said, Portugal's comes up and it's not because their law enforcement's any tighter than ours. It is just because they've done some decriminalization, but also, as you said, they've invested on the front lines of addiction management.
Okay. Mia, do you want to take that a little farther into the treatment of addiction management and the availability of services? I think we talked about the RAM clinics, but in general, addiction services across Simcoe County or in this area and where we stand compared to others?
Well, certainly, I know that the Canadian Mental Health Association provides services in our region. But I think to add to the discussion about the supports in a decriminalization situation, we also need to increase supports in social services and housing. So we know that there is evidence that not only is treatment necessary in a decriminalization situation, we also need to look at the social services being amplified and available so that people are properly housed, have access to stable housing, access to stable food supply, and as well as all the other social and health treatment services.
So back into the determinants of health and that discussion, which we've had 2 or 3 times on this show before. So yeah.
Yes,
okay.
absolutely.
Okay. A question that's just come in from Facebook Live. Is there a trend between mental health challenges and drug use? This is a circle question, I'm sure, but who wants to tackle that?
I can take a stab at it first. Sure. There's definitely, and this is one of the theories of why the things have gotten worse during the pandemic, and access to mental health services has gotten decreased. And drug use is a form of self-treatment for many depressive anxiety disorders. And as the accessibility to mental health has decreased, and we've seen a huge increase in mental health burden with pandemic, it's one of the reasons why our both drug uses and drug overdoses has gone up. Some of these drug overdoses are intentional suicide attempts as opposed to just overdosing, recreationally. So there's definitely a correlation.
Okay. Thanks. Let's see here. Let's see. What relationship does cannabis have to all of this? Is cannabis, I guess we've gone through the evolution. When did we legalize cannabis? A couple of years ago, Jim?
2 years ago.
And has that made the opioid crisis worse, better, difficult? Is it associated at all?
No, like from a law enforcement perspective, we legalized cannabis October 17th, 2018, and the sky didn't fall. I in my portfolio, I have cannabis enforcement. I can tell you our efforts are strictly based on organized crime. We haven't seen a direct correlation to the opiates. It does come up in the discussion about pain management and those types of things, but from a law enforcement perspective, not seeing a direct correlation.
Chris, in your world in the ER?
Yeah, definitely looking at the evidence for that, Keith, that there's there's sometimes you get some correlations in some study, but definitely no causation. So the whole idea of it being a gateway drug relates back to a study from the 70s. But when you look at people who use cannabis and then go on to use harder drugs, narcotics, it's not seen to be that there's no link that using the cannabis then set the individual down a pathway to use harder drugs. So the same stresses that cause potentially the use for cannabis for the same stresses that would cause them to use something harder. Then there actually is some counter evidence showing that in people who use more cannabis actually protects them from using harder drugs as well. So no evidence that they're linked as a gateway drug.
Okay. Melissa, in your mom's conversations, where does cannabis fit?
I believe that cannabis can be a gateway drug. Is a gateway drug, not for everyone, but I think it is. It can be certainly the start.
Okay. Slightly different opinion, but thanks for sharing. Where do people get the money to buy the bad drugs? Like, is this just these drugs are not inexpensive. Am I right, Jim? How much would they pay for?
Well, right now with COVID, we're seeing fluctuations. So when they're buying it from the point, we're seeing it as low as 25 during sometimes up to $75, $80 a point. So that's a hard question. Like, there is sometimes some associated crime, in order to fund their habit. Like I said, the money can come from any number of places.
Okay. Sorry, I'm just reading through these questions. Okay. Let's talk a little bit about the people at risk of becoming somebody that needs opioids and then therefore is subject to finding or buying or receiving opioids that are laced with fentanyl. So you've talked about something that goes on very early in life that might actually be part of this problem. Are there other indicators that we should be looking for from a societal perspective that say, hey, this person actually they're not taking opioids right now, but given the wrong set of circumstances and the wrong choices, might actually go down this path? And would they be well to get some preventative therapy at this point? Other risk factors I'm asking about. Jim, Chris, Mia?
I think maybe I'll start and I'll just I'll say I think like from a law enforcement perspective, that's what we're looking for. I mentioned the Stats Canada data project we're looking at is looking for those factors, whether it be socioeconomic, something in their health, an injury they had, all those things. And trying to really paint a picture of who this is impacted. So maybe we can look back, for us, are there some pathways or some opportunities before they fatally overdose where maybe law enforcement, harm reduction workers or the ER had an interaction that we could look back and are there key indicators to that point? To get into, we don't diagnose and nor do we, start to go down, what happened or what caused. That's a pretty complex question to answer.
From your world, Chris, any risk factors that kind of are starting to stand out or people starting to think about?
Yeah, there's been no concrete ones that we said for someone who's never been addicted to another, like benzos, for instance. If we had a solid predictor, then we have a risk factor for prescribing that person opiates, let's say post-operatively after a surgery. I think that the only flag I could see was if someone's been addicted to another, kind of class 1 substance like benzodiazepine, then that would be a flag for me. But I'm not aware of any other, kind of predictors that would say, this person probably shouldn't be given any opioids.
Alcohol addiction or heavy use of alcohol? Is that
Again, there's a correlation there, but I don't know of any evidence of a causation with alcohol.
Okay.
I think it's safe to say that people, sorry.
Yeah, Melissa, go ahead.
I think it's safe to say that people often use substances to make them feel better. And so, there's been a lot of work that's been done by Dr. Gabor Mate, who was one of the lead physicians at Insight in Vancouver, who shared that a lot of the clients he saw at Insight really had, traumatic experiences at some point, abuses of different types at some point in their life. That's not to say everybody goes through those experiences when they have an addiction, but certainly it can be one of the main causes for someone who is experiencing addiction with substances, because a lot of the times they'll say, ask not why the addiction, but why the pain.
Okay.
If I can speak to, as a mother with Luke, I missed the early warning signs. I look back now. I do believe that Luke suffered mental health issues. And I wish that I could reverse time and go back and say, you know what, I should have done this. I should have recognized this sooner. Luke was using recreationally. Would have he been an addict? I don't know. But I do believe that he was self-medicating. He was definitely using cannabis. And it turned out it was heroin laced with fentanyl. But as a mother, I look back and I wish I would have had more education of being able to recognize the warning signs earlier. And even just from my experience, being able to share that and being able to talk openly to other parents to recognize when your children are younger, what could trigger their depression, their mental health, their substance use.
Okay, thanks. So some early warning signs as you look back, definitely. Okay, thanks. For Inspector Walker, comment on the benefits of the community if there is a local supervised drug center. Does this make your job easier or more difficult? And go broader than that. So does this make a difference to the work that you do?
No, I wouldn't say so. And the reason I say that is because I've visited a number of supervised injection sites. We, along with the members from Barrie City and a number of services, a number of years ago when this was first becoming a discussion, had an opportunity to tour a number of the sites in the Greater Toronto area. And I can tell you, and again, I keep referring to Mia. We work so closely together. She knows more about it. But
I don't know whether we introduced the two of you. You both sit on the same committee at SIMCOE County Strategy for opioid, the opioid challenge, and maybe we didn't make that clear before.
I want to be clear too from the OPP. Barrie Police has obviously been engaged with that application, but I'm speaking from our experience, and what I can tell you is it comes down to location and the community involvement in it. And the reason I say that is I saw a number of them that you wouldn't even know they were there if we weren't taken there. So we haven't seen, and I can say, from an OPP perspective, Barrie City Police would have the stats, on locations and stuff like that. But the great thing about it is that they are engaged, and these applications, when they do come forward in whatever community, there is engagement with the local law enforcement to say, are there these factors being taken into consideration?
All of you sit on committees that are trying to make a change, but ultimately you have to change policy somewhere. Sometimes it's just at the local hospital, Chris. Sometimes it's in the Barrie community council issues. Sometimes it's as high up as the Ontario government. How do you get heard by the policymakers? How do you get your message across? All of you can weigh in on that one.
Again, I'll start having the data to back it up, not anecdotal stories, but actual physical data. I know from law enforcement, when we're pushing for new initiatives and stuff like that, you want to come with evidence-based solutions. So I would start by saying having the data to back it up.
Okay. Chris, Mia, any further on that, or Melissa?
I would definitely add that, data drives decisions, and especially in the hospital, and you need to show the data. I think that, having someone like Melissa who went through this and putting the human face to the data is very powerful. And I think that the combination of the two is the best way.
Okay. Mia, any further comments on it?
I would say that communities of practice, locally and across the province, help for lobbying the government when we want to advocate for changes to policies around, anything related to the opioid crisis.
Okay. Speaking about data, somebody's asked here some data. Chris, how many opioid related emergency visits do you see at RBH, at your emergency department? I don't know. What do you see? 100,000 patients a year in your emerge, something like that? How many would you see in a year that were opioid related?
Yeah, we're getting close to probably 80,000 visits a year. And the numbers it's hard to track the numbers sometimes because we have overdoses and the overdoses that are given Narcan. And on a given month, there's probably between, there's at least, we're approaching one a day in the summer, and some days it's, 4 or 5, but on average between, 20 to 30 a month. And that number's, if you see, look at the graphs for Ontario, and, you see since about 2013, the numbers start to climb up and they keep climbing fairly steadily.
Okay. Somebody's asking, sorry, go ahead. Go ahead, Mia.
We had over 600 overdoses in our region in 2019. Those were ED visits related to overdoses across the region.
Okay, so it's a big number when you think of it. Okay.
It's higher than the provincial average.
Somebody has asking, where's the best source for education? We gave identified a couple of papers, one from you, Jim, and one from the OPP, and another one from the Canadian government. Any other suggestions for giving that people want to read more about this, where they should go?
I would echo Mia's, especially for local, is the preventod.ca site that outlines and has.
So you just want to say that slowly again, Jim, so that we get that?
I'll let Mia just because I want to make sure.
Okay, Mia, go ahead.
So it's preventod.ca.
Preventod, all one word, .ca. Okay, thank you.
That's correct.
Thank you.
That has a lot of the local information and resources.
Okay, okay. Kind of like to sum this up, and I don't do this very often, but I'm going to ask for some key messages from each of our speakers. You're all very knowledgeable in this area, but if you had one thing that you think that would make the biggest difference, can you tell us what it would be? Now I say the biggest difference, so I'm not asking for the one that is the easiest to implement or that takes the shortest time to implement. I'm asking for the one piece that you think would make the biggest difference. Who wants to start with that one?
I'll start from a lived experience. I would say it's the funding. We need money. We need money for health, for all areas of, police, hospitals. We need wraparound services, and there is not enough funds to even come close to addressing this.
Okay. Chris, what's your feeling?
I think that we need to really address as a community stigma around drug use and addiction. And I would like to see everyone treat addiction and drug use like diabetes. It's a disease that's chronic, that people battle their whole life, that there's drug treatments for, but there's also lifestyle modifications for, and also social changes.
Okay. Mia?
I would echo both Melissa and Chris. I think, stigma is a big piece, and we need to address that in a big way in order to make any monumental changes in this crisis.
Okay.
Yeah, and I would surmise everybody's statements, everything from wraparound services, treatment on demand. If somebody has made the decision that they want help, that they can get that help immediately, and then just treating everybody with a bit of compassion. Melissa had said it. We seem to be at times at odds, and that's what I do like about the committees, that we all sit apart. We all have different lanes that we stay in, but the information that comes from everybody and the partnerships, is you start to see that compassion there.
Okay. Rapid RAM clinics, rapid addiction. Sorry, go ahead. You go ahead, Mia.
Rapid access addiction medicine.
Yeah, those were put into place a couple of years ago, and we all were welcomed that addition. You've all talked about making sure these people get assessment quickly as possible. Are they helping? I thought that was one tangible thing that we actually had put in place.
I can't really speak to the work that's happening from the RVH RAM clinics, but I know that they do operate in a number of communities across our region. I believe I have that data in front of me. So they operate in Midland, Barrie, Wasaga Beach, and Orillia at this point.
Okay. Chris, any follow-up from your perspective, from a hospital perspective, one that's running there?
Yeah, no, I mean, they're definitely up and running. They seem to be, successful. They do tend to treat more alcohol-related addiction right now. And I don't know how. I know when I called recently after the pandemic first started, I know their hours have been changed. They were trying to do virtual appointments, but I know that their capacity definitely been decreased. But I imagine they probably try to ramp up as much as possible given the increasing demand.
So just Google RAM, is that what, RAM, is that what you do to find out where they are and how you can get a rapid appointment?
Yeah, you can also go through the RVH website. I believe it's on there as well.
Okay, thanks. Well, as I look at the time, I think it's time for me to start to wrap up. It's been such a delightful and informative evening. I've enjoyed talking with each one of you. Great audience to have. We know that there's a lot of people out there from the number of questions that I've got in front of me. So that's been wonderful that you're engaged. We've been able to shed some light on the topic and understand the magnitude of the problem. Each one of you has added to that so well. We've learned about some of the solutions and which organizations are responsible for spearheading those solutions. And I think we've understood, particularly Melissa, from you, the importance of us collectively and the work that we do. And you've really brought that home to all of us, that each one of us has a responsibility for doing something. Sincere thanks to the four of you. You haven't come from a distance, but you are all from a distance from where we're having this tonight. But each one of you has taken the time to meet with us beforehand, to hone in on your discussion with me, to think about this, and a huge amount of the time that you spend every day in working at trying to do something about the opioid crisis. In addition to just coming here tonight, it's been insightful to see just how much time and how much work all four of you put into it, and so many others do. So thank you. And in conclusion, I'd like to hear from from our audience. We don't know where you're watching from or how many of you are out there. So if you liked our program or if you think we could do better, please send a note to Jared. I think you have that address. So again, thanks to our sponsors, and we'll see you in 5 weeks for Resilience. Take care. Enjoy your evening.
the Rogers TV viewer response line, email us, or connect with us on social media.
I'm Captain Kidd. Captain. Little girl is lost. I'm taking her home.
How much you want for her?
This child is not for sale.
You can't have her!
Every week, I go to a club. I act like I'm too drunk to stand. And every week...
Oh, I thought that you were...
Really drunk?
Yeah.
I'm not.
I was a nice guy.
Are you?
This is Rogers TV.